tồn tại túi lết hay là tiểu sản thùy nhộng, vì hai bên tiên lượng hoàn toàn khác nhau. Thì nó rất là khó, tại vì cái góc thùy nhộng nó không hề bị di lệch gì hết, nó vẫn ở vị trí bình thường nhưng mà cái kích thước nó nhỏ. Thì cuối cùng cái ca này làm MRI á, thì sẽ thấy cái thùy nhộng nó bị nhỏ. Tất nhiên có một số trường hợp các anh chị khó khăn thì các anh chị cần có sự hỗ trợ MRI. Thì như vậy đây là một cái trường hợp là thiểu sản thùy nhộng. Thì tóm lại đối với cái bài bất thường hố sau thì Nguyên muốn nói lại nhắc lại các anh chị, đây là một cái vấn đề thường gặp. Và cái dạng bể lớn hố sau đơn thuần cái tiêu chuẩn chẩn đoán khá là dễ, nhưng mà chị phải cắt dọc lại để các chị đánh giá thùy nhộng. Cái Dandy Walker malformation là một cái thể nặng các anh chị cũng dễ, nhưng mà thật sự là nó quá rõ ràng cho nên chẩn đoán không khó. Cái vấn đề khó đó là cái sự toàn vẹn của thùy nhộng để các anh chị phân biệt giữa tồn tại bullet là tiên lượng rất tốt và một bên là thiểu sản thùy nhộng là nó sẽ ảnh hưởng đến những cái rối loạn hành vi. Cho nên cái vấn đề hố sau nó khó nhất là cái đánh giá thùy nhộng, mà nhiều ca Nguyên cũng gửi cho thầy PHILLIP JEANTY và thầy cũng hỗ trợ trong chẩn đoán, và thầy nói cái câu là tôi rất ghét là vẹt mít, I hate vẹt mít. Thầy nói với Nguyên như vậy là các anh chị thấy là đánh giá cái vẹt mít nó rất là khó, cho nên đó là một cái rất là quan trọng để đánh giá phân biệt giữa tồn tại duplex và một cái thiểu sản thùy nhộng. Xin cảm ơn sự lắng nghe của các anh chị.
Xin cảm ơn thạc sĩ bác sĩ Hà Tố Nguyên đã giới thiệu về cái bất thường hệ thần kinh trung ương. Bất thường hố sau là cái bất thường hay gặp nhất về cái siêu âm tiền sản. Và ngoài cái phần giới thiệu hình ảnh thì báo cáo viên còn giới thiệu giúp cho chúng ta những cái kỹ thuật để có thể dễ dàng phát hiện và phân biệt với lại những các cái trường hợp khác. Thì tiếp theo chúng ta chuyển sang cái bản báo cáo thứ hai. Báo cáo của thầy PHILLIP JEANTY là bất thường đường giữa midline anomaly. Thì tôi cũng xin giới thiệu một chút về thầy PHILLIP JEANTY. Giáo sư PHILLIP JEANTY là giám đốc đơn vị siêu âm ở cái trung tâm hình ảnh săn sóc về các cái vấn đề bất thường có di truyền ở bang Tennessee, Mỹ. Và giáo sư JEANTY là người sáng lập cái trang web Fetus.net, và đây là giáo sư có nhiều kinh nghiệm trong lĩnh vực siêu âm sản, dị tật và sàng lọc trước sinh. Xin kính mời giáo sư PHILLIP JEANTY, please.
Good morning. So we're going to talk about two of the topics in the central nervous system anomalies, and I'm going to start with the midline cyst. Now, what is the process to think when you find a cyst inside the baby's head? What is the characteristic? So let me start to go back. So the first question is that, is it just a cyst or is it a different type of fluid collection? So let's assume it is just a cyst. And then the question is this exactly midline or is it not exactly midline? So let's first start with an exactly midline cyst, and then we have the choice between these four groups. So let's start with the cavum septum pellucidum and the cavum vergae. So these will be exactly central like this, and they usually communicate together. So when you have a cavum vergae, it appears as a prolongation at the posterior aspect of the cavum septum pellucidum, and this is what you see with ultrasound. You see this big cyst in the middle. It's more visible when you do the sagittal section, but I'm looking here only in coronal section. The next type of cyst you can find is an interhemispheric cyst, and this, as you can see, is very strongly associated with dysgenesis of the corpus callosum, which we'll talk about later on. And so there you think about a herniated third ventricle that pushes in between the interhemispheric fissure. You can also have neuroenteric cysts, acromion cysts, and epididymal cysts. So the appearance here is a cyst that is strictly midline in between the two hemispheres. Now, another type of cyst you can find is a cavum villi interpositae, and these are more posterior, and it's in the space above the telachoridae and the ventricle, and it's between the columns of the fornix that are in the posterior aspect. And if you do an ultrasound, this is what it will appear in the posterior aspect. Next, I wanted to show you the arachnoid cyst, and as you can know, arachnoid cysts only develop on the surface of the brain, on the arachnoid, although you can see that the arachnoid can invaginate itself in many areas, so it will not be inside the meat of the brain, it will be on the outside of the brain. And there will be subarachnoid, so at the periphery of the gray matter of the brain, and the most common area is the sylvian fissure, the posterior area, and look when they're in the posterior area to differentiate them from Dandy Walker cysts. So you use the algorithm that Nguyen gave you in the previous lecture. They do not they displace, but they do not disrupt the cortex. It's an important differential diagnosis with the parencephalic cyst. So the appearance here will be some cysts that are on the surface here and displacing the brain itself, but not destructing the brain. So now we've explored this branch, let's go back and let's say, no, it's not exactly midline. So now we're faced with three choices: guard plexus cyst, suprapendular cyst, and again arachnoid cyst. Guard plexus cyst, I'm sure you have seen a million of them. This is something that used to be very important 20 years ago. Now we don't pay too much attention, but remember the association with trisomy 18, 21, and with Klinefelter. And of course, this is the appearance of guard plexus cyst. Sometimes when they're quite symmetrical, they may not be so visible because they appear to be a section through the lateral ventricle, but so pay attention to the symmetrical one. Subependymal cysts, there are several of them. The least likely to define are the conatal cysts, which are adjacent to the supralateral margin of the body and the frontal horns, and they can be a normal variant. So if you look over here, we have this little cyst, which is at the edge of the lateral ventricle. Remember this image because I'm going to show some differential diagnosis in the next slide. The next one, which are much more common, are the subependymal cysts, and these are the sequela of a bleed, and I could show you the bleeds later on, but I don't know that I will have time. And this is a sequela of germinal lysis. So this is the appearance of those cysts, and you can see here we have the ventricle, and just under the side of the ventricle we have those two cysts. So this baby at some point had some bleeding in the germinal matrix. Now remember, there's a gradation of grade 1, 2, 3, 4. If you have a grade 4 bleed, there will be an intraparenchymal extension of that bleed, and the result of this intraparenchymal extension is going to be a much different cyst, which is what you see over here. These have a much worse prognosis, and they are bigger, they are more peripheral, and they are more superior than the other one. And then we had also seen the arachnoid cyst, so we can go back out of that. So now we had seen the midline or not midline, so we do back in the differential diagnosis and say it's not just a cyst, there's something more than just a cyst. So the next question is the cavum septum pellucidum present? So let's say it's present. Is there an interventricular fissure? Let's assume there's an interventricular fissure. And then the next question is, do you see the corpus callosum? Okay, let's say it's there. So the next question is there ventriculomegaly? Yes. And then you have either mild or ventriculomegaly. Mild ventriculomegaly, as you remember, is an atrial measurement less than 15 millimeter. And this is what you see over here. We have some slight distension of the ventricles. You can see the occipital horns have been distended. You see also there's some germinal-lysis here, and there's some subependymal cysts. This is typically after a bleed. The bleed not only causes some obstruction of the granulation of Paccioni, but it also obstructs the aqueductus of Silvis, and so you have several reasons to develop hydrocephalus. Or you can have a real ventriculomegaly, and then the question is, do we have a dilatation of the ventricle, hydrocephaly, or do we have atrophy of the cortex? So you can have large ventricle for two reasons. Either you have increased pressure, which is ventriculomegaly, or you have atrophy of the cortex. You can also put color, because in color you can see that this baby may have actually a vein of Galen ectasia. So important to use color when you do that. So here would be an example of that. You see distended ventricles, they communicate here in the middle, and then we go into all the differential diagnoses of the holoprosencephaly and things like that. Let's go back in here, and let's say there was no ventriculomegaly, and then is the brain parenchyma intact? Okay, yes, the brain parenchyma is intact. Then we have to differentiate between the septo-optic dysplasia and absence of the caveum septum pellucidum. So let's go for septo-optic dysplasia. So here we have no caveum septum pellucidum, and we have fusion of the lateral ventricle in the midline, and this is very similar to what we see in holoprosencephaly, and this would be an ultrasound image of that. You see the two ventricles are communicating, and you see there's an intermittent fissure in between. So this is septo-optic dysplasia, and a very difficult differential diagnosis is absence of the caveum septum pellucidum, in which you have also merging, but this has a much better prognosis. So here we have an intermittent fissure and the forks that are present. We may have some corpus callosum, we should have corpus callosum, and what you want to think here is schizencephaly, septo-optic dysplasia, some holoprosencephaly, hydrocephalus can also do an image like that. So a big differential diagnosis when you look at that, and here's an example of septo-optic dysplasia where you see the merging of the two, and you see the intermittent fissure which is present in between. So let's go back out of that, and let's say the brain parenchyma is not intact. So if it's not intact, do we still have gray matter or not? Let's assume that the gray matter is present. Then you go back to the subependymal cyst that we saw earlier, go to proencephaly, which is a result of an infarction or defect, or schizencephaly. So let's try proencephaly. So here we have large cysts, and those cysts can be divided essentially into two groups. Those that have communication with the external aspect of the brain, so they communicate with the subarachnoid space, and those that communicate with the ventricle, so they have an internal communication. And often you want to look for some little septation between these. So this typically are going to be cystic degeneration of encephalomalacia from ischemia, hemorrhage, infection, and they will result in a hypoechoic lesion afterwards. So the ultrasound image here will be some big defect, lacunae, and then you try to see whether they communicate with the ventricle or more with the subarachnoid space, as in this case here. Now the next differential diagnosis here would be schizencephaly. Now schizencephaly is classically divided into two groups. Those that have open limb schizencephaly, which is by far the majority of those that we see prenatally, and there we have a big brain gap, and this is typically resulting from a middle cerebral artery occlusion or a middle cerebral artery infarct. And these are very simple to recognize with ultrasound. They can be unilateral or bilateral. And you can have the basket handle, and I'll cover this in a different segment. Now there's another type called the closed limb, in which there's just a thin line defect that communicates between the subarachnoid space and the lateral ventricle. And this has almost never been diagnosed prenatally. So this is a much rarer case. And so this is one of the reasons why ultrasound is not sufficient. You may have to do MRI on these babies to look for the closed version. So let's go back now, and let's say the gray matter is absent. Well, now of course we're talking about a very bad disorder. We're talking about hydranencephaly. And here fundamentally the entire brain has disappeared. And if you catch it early on, you will see the baby's brain liquefied. So you have low-level echo and the brain has kind of liquefied. This happens usually after bilateral occlusion or infarction in the territory of the internal cerebral arteries. Now, importantly, in hydranencephaly, you preserve the force, or you preserve something in this region, which is important in the differential diagnosis with lobar holoprosencephaly. And here's an example. You can see a big black spot inside the head. There is some fusion of the thalami, but you have a little bit of interhemispheric fissure which is present. Watch out that it's easy to confuse an interhemispheric fissure with some cyclo artifact. So you have to reorient and see from different angle to make sure that you truly have a midline versus no midline, because it will change the diagnosis to lobar holoprosencephaly. So we have explored this here. Let's go back one level, and let's assume that the brain parenchyma is not intact now. Now, is there some gray matter? Well, again, we go back into this. We'll go back one. The gray matter is absent. Again, we go back to hydranencephaly. So we go back one more time. And is there ventriculomegaly? Now, let's say there is no ventriculomegaly. And then we go back to the same differential diagnosis. Okay? So this is a differential diagnosis that allows you to go into the different versions. So here, absent interhemispheric fissure. Now, when we have absent interhemispheric fissure, we are going into the holoprosencephaly. And I'm going to cover this in the ventral induction in the next presentation. So let me save that for that moment. So I think we have explored all the different regions here. So let me go back to the main menu, and we're going to look now at the topic of the ventral induction defect. So, ventral induction. So let's start with the cases of dysgenesis of the corpus callosum. And with the dysgenesis of the corpus callosum, the one that we see much most frequently is the total absence. So here we have the zero communication between the two hemispheres. The fiber of white matter that should have been connecting the two hemispheres in the brain fail to develop transversely, and they become longitudinally oriented. And I'll show you this as in image later on. It's called the Props bundle. Now, this happens to be a disorder of the cilia. This is a ciliopathy. And this is a topic which is developing, and so let me spend just 2 seconds to show you what the ciliopathies are. Cilia are elements inside the cells, and they are involved in the motion and the transport of different elements inside the cell. And in the case of ciliopathy, what we have is we have gene defect that go to either a defective protein, or this is a defective morphology, or a defective protein that results in an abnormal function of those cilia. Because of that, the element inside the cell don't move properly. And as you can see, cilia being part of all the different cells, they may be associated with many different types of disorder. And many genes are involved. So many of these conditions, which we used to classify by timing of occurrence, are now classified by pathway of defect. So among the ciliopathy, you can see have very different conditions. Here we have Schubert syndrome, which is the vermin aplasia, the moldy tooth appearance. But we can have Cartagena, we can have situs inversus, isomerism, which we're going to be discussing later this morning, polycystic kidney disease. So you see, this is a very wide set of disorder due to this different pathway that are damaged. So we'll review this also when we do the Joubert syndrome. Now, why do we have the defect? Most of the time, it's multiple genes that are involved, but some toxic, alcohol and cocaine, can also affect the ciliopathy. Then you can have cytomegalovirus, which is a very common reason to get dysgenesis of corpus callosum. And then you have metabolic errors, so the non-ketotic hypoglycemia, and then the pervasive development disorder, which is essentially the autism spectrum and the Rett syndrome. So a wide region of anomaly you can have there. Now, what are the different appearances? Well, if you look first, a total agenesis, you don't have the corpus callosum. And because you don't have the corpus callosum, the gyri that was supposed to be parallel to the corpus callosum are not forming, and they will be oriented radially. So you have these radially oriented folds, and you don't have the septum pellucidum. So when you compare to the normal, there's a big difference here, and that is something that you can detect using the sagittal section that Nguyen showed you in the previous presentation. Now, instead of having a full corpus callosum, you may also have an anterior dysgenesis. So you see here, the genu of the corpus callosum is missing, or you can have a posterior dysgenesis, the splenium is missing. You can have hypoplasia with a very thin corpus callosum, and there are some measurements that have been published in the literature, so you can see the different size. And then you can also have dysgenesis in which you have a ratty-looking corpus callosum. It's irregular. Some places are thin, some places are thick. So these are the different forms to look for. Now, if you look with the ultrasound, you have several sections that we typically use. If you go in the transventricular section, this is what you should see in the normal fetus. You should see the two ventricles that have this normal shape that we're used to. And if you compare the normal to the dysgenesis of the corpus callosum, now you have the teardrop shape of the ventricles. So you have what is called colposymphony, with the occipital horn larger than the frontal horn, and the occipital horn are closer together than the frontal horn. And when you do an ultrasound image of that, you see the distension of the frontal horns with the pointy shape of the anterior aspect. And you also see, because of that, because the corpus callosum is not there to attach the two hemispheres together, you see that the frontal lobes are more separate. So you have this wide interhemispheric fissure. So this is what you see in the transventricular plane. If you go into the transdynamic plane, this is the normal image. You should see those comma-shaped frontal horn, you should see the cavum septum pellucidum, and you should see the occipital horn in the posterior aspect of the image. And when you have cases of dysgenesis of the corpus callosum, first you're missing the cavum septum pellucidum, and the anterior horn are going to look parallel instead of diverging. And of course, they are more close than they should be, and then you have dilatation of the occipital horn. And when you look at the ultrasound, you see those parallel horns here. You see no cavum septum pellucidum, but you see a large third ventricle. So be careful not to confuse the large third ventricle for the cavum septum pellucidum. Once you have then these two transventricular transdynamic view, you can go into the coronal view, and this is what you expect to see in the coronal view. As Nguyen has shown you, you should see the corpus callosum bridging the two interhemispheric distance, and you should see a thin interhemispheric fissure. In dysgenesis of the corpus callosum, what you have is a wide interhemispheric fissure. You see that the third ventricle is not delimited superiorly by the corpus callosum, and so it extends higher than it would normally do, and you see a wide separation of the anterior horn. And this is the ultrasound appearance, where you see the high riding third ventricle, you see the wide separation of the anterior horn, you see the wide interhemispheric fissure with 3 lines at this level. And then finally, the other section you can get is, after the coronal section, is the sagittal section. Now we're cutting front to back, and instead of seeing the corpus callosum and the precallosal gyrus, thing like that, and the normal distribution of the arteries, in dysgenesis of the corpus callosum, you have those radial folds, and you have a Bernstein sign, and you have not the normal distribution of the pericallosal artery. And with ultrasound, what you see, you have to do Doppler, and then you see, instead of the nice curve of the callosal and pericallosal, callosal marginal artery, you don't see this anymore. You just see radial folds that come from the center. So these are the views that you will try to get when you do this examination. So here we have wide separation of the hemisphere. You see 3 lines instead of seeing 1 line. There is a teardrop configuration, which is easy to see. You see the pointy frontal horn, and you see the colpocephaly in the back. And here, when you look at the semicoronal view, you see the third ventricle here is almost touching the forks. The third ventricle should not be touching the forks. There should be some space in between, because you should have the corpus callosum at this level. So these are the findings you want to look in this region. Then, here's another example. You see the colpocephaly with a wide occipital horn, the pointy frontal horn, and you see that these frontal horns are parallel to each other. They are not diverging like normal frontal horns. They are parallel to each other, and when you do a sagittal section, you see those lines here are the radiating gyri instead of being oriented alongside the corpus callosum. So that's a different image that you have to try to get for this sagittal section. Another example of colpocephaly, you see the distended posterior horn, you see the pointy anterior horn, and you see that instead of the normal radiation of vessels, you have this kind of bizarre disorganization of the vessels. So these are easy signs to recognize, but you have to pay attention and you have to look at the proper section. Here we see no genu of the corpus callosum, and we see no corpus callosum between the left and right hemisphere, and again we see disorganization of the gyri typical of agenesis of the corpus callosum. Now, the interhemispheric fissure is not retained by the corpus callosum, and so the third ventricle can extend more symphatically, more rostrally, and it can separate and cause an interhemispheric cyst. And I'll show you in a second, there are 2 types of interhemispheric cysts, whether they connect or they don't connect with the third ventricle. So here we have, oops, sorry, went too fast. So here we have a large interhemispheric fissure cyst. You see this big cyst separating the hemisphere. You see the colpocephaly over here, and you see the organization here of the interhemispheric cyst and the teardrop configuration. So this is a classical form of the interhemispheric cyst. Again, here you see 3 lines between in the middle. Here you should not see 3 lines, you should see only 1 line. You see the teardrop shape of the lateral ventricle. You see those 3 lines, very characteristic. This gives you the diagnosis of agenesis of the corpus callosum, so you can be pretty confident of the diagnosis you made. So I mentioned to you the cross bundle, which are those axons that instead of crossing over from one side to the other, don't have the massa communautaris in order to bridge, and because of that they cannot cross over, and they go longitudinally, and then they cross those bundles over here. And this is a MRI image with tractography, something we cannot do with ultrasound. Another example where having MRI is useful in the diagnosis. Now sometimes you can see some widening of the space between the frontal horn because of this cross bundle that are displacing the medial wall laterally. But this is actually not a very easy observation to make. But when you see the colpocephaly here, this is something that you can think to try to recognize. Now, here we're going from top to bottom in the volume. You can see the interhemispheric cyst. You can see the three lines. You can see the wide separation of one hemisphere compared to the other hemisphere. And here in the coronal section, again, we see the separation and the cysts in between, and no corpus callosum bridging the two hemispheres. So, very secure diagnosis here. Here, another complication that can happen, you can have lipoma of the corpus callosum. So you have this wide echogenic fatty tissue tumor that is at the level where the genu of the corpus callosum could be. Now, the interhemispheric cyst can be divided into type 1, which is a diverticular or an extension of the third ventricle, or type 2, in which the cyst is loculated and not communicating with the lateral ventricle. So, yeah, you may try to recognize one from the other, which with ultrasounds is not quite as easy as it is with MRI. So here another example, we have a thin cavum septum pellucidum, we have a dilated third ventricle, and we have some wide anterior horn that are parallel to each other. We see some random organization of the folds and of the pericallosal artery. And you can see here that we have a portion of the anterior corpus callosum, but we're missing the portion of the distal corpus callosum. So in partial dysgenesis of corpus callosum, it's a bit more difficult to recognize than in genesis. It's easy to confuse partial dysgenesis for a normal corpus callosum. Here's another example. You can see that the corpus callosum is too thin for the anterior portion and next to the genu, but you see the body of the corpus callosum and the splenium are not seen. Another example of a baby here that has French syndrome with hypoplasia of the corpus callosum. So, after this, let's go into the topic of the holoprosencephaly. And holoprosencephaly can present with a great variety of appearance, and I'm going to try to show you the most common one. So this is a group of disorder of the development of forebrain and midface, and we'll look at the midface afterwards. And it results from a failure of differentiation of midline cleavage of the prosencephalon. It affects the anterior infantile lobe, the deep gray nuclei, the olfactory region. It's not that uncommon, 1 to 2 per 10,000. The alobar form is something that everyone has diagnosed. The lobar is much harder to recognize. It can be associated with trisomy 13, 18, triploidy, Danny Walker, and there are multiple genes that have been recognized to be involved in holoprosencephaly. So these are the different types. So if we start with the normal one, compared to that, the most abnormal one is the alobar holoprosencephaly. This is the most severe form. There is no interhemispheric fissure and no force in those babies. And they have a undifferentiated ventricle that you can see over here that bridge both sides. There is no third ventricle. And the roof of the ventricular cavity, which is normally covered by the brain, may balloon out to form a cyst. And we'll see how this is divided into a pancake, a cup, and a bowl form in the next few slides. The next, more severe, is the semilobar form. In the semilobar form, you have a partial posterior separation of the ventricles, so there's an attempt to separate them, but the front is still merged together. And the roof of the ventricular cavity, which is normally overlaid, also may balloon in the front. Now we move to the lobar form, and the lobar form is the least severe form. There's almost normal separation in the hemisphere, but there's some fusion of the ventricle here in the middle. There is no cavum septum pellucidum, there's no olfactory bulbs and tuck, and the corpus callosum may be absent or hypoplastic or normal. Now compared to this form, there's a more recently described form called synthelencephaly about 20 years ago, and this is also called the middle interhemispheric variant. And here this is an intermediate form between the lobar and the alobar variety. There's more differentiation in the frontal lobe than in the alobar, and there's one single ventricle. There's also some posterior differentiation. But most characteristic, the ciliary fissure seem to extend from one hemisphere to the other hemisphere. So it's mostly in the middle portion of the brain you see the defect, which is the reason it's called the middle interhemispheric variant. And there's a very rare form, the holodosencephaly, in which the frontal horns are well developed. There's absence of the septum pellucidum. They have hydrocephaly, and they have fused fornices in the coronal section. But I don't have a picture of that prenatally. So remember the week 3 to 4, as Nguyen has mentioned, is the dorsal induction, and week 5 to 10 is the ventral induction, in which segmentation of the brain occurs. You have the division of the prosencephalon, and you also have formation of the brain, of the face. Remember, the undersurface of the neural tube here is going to be inducing the formation of the face. So normally you should have the initial vesicle that has a cleavage, and then the two lateral fold rotating wall. You have proper lateralization developing normal ventricle. If you have failure of cleavage, you will have failure of inward rotation, and that will cause the fused ventricle and the dorsal sac with a single ventricle that we typically see when we do the A-lobar form of holodosencephaly. So let's start with A-lobar, which is the one that we see the most easily. You can start recognizing that very early on. And these are babies that have a big cyst inside the head, and importantly, you should not see an interhemispheric fissure. So look for a thin, incomplete brain, and we'll talk in just a second between the pancake, the cup, and the bowl. There's a monoventricle communication with the dorsal cyst. The thalami are fused. There are no corpus callosum, no folds, no interhemispheric fissure in those babies. This is a lethal condition associated with some major facial anomalies also. So this is the 3 type. In the pancake form, you have brain, which is just at the most inferior portion with a big cyst above that. And this is what you see in the ultrasound image, a large cyst and just a little edge of brain in the most caudal portion. This is the pancake. This is the cup here. So now the brain is extending and covering the frontal region, but not covering the entire region. And this is what you see in this ultrasound image, with the frontal portion being developed, but the back is missing. And then the last thing is a bowl form, in which there's a thin layer of brain all around, a large cyst, and this is more common in semilobar holodosencephaly. So here are a few examples. You see communication of the ventricle from one side to the other. You can recognize that pretty early on. This is a case we had at 11 weeks. This is another case at 12 weeks. This is something which is recognizable when you do nuchal translucency screening, for instance. Here are some other cases in which we did the dissection of the ventricles by doing an inversion. And you can see the big ventricle going from one side to the other side. And you can do this, it's a bit tedious to do, but you can do this at different gestational age. Now, if you section this A-lobar holodosencephaly at different level, at the top here, you have this large communication. You go more in the middle, you have the cup form, and here you get to the bottom portion, and you see the fused thalami at this level. Another example from Nguyen here. This is the bowl form. You see the communication between one side and the other. You see the frontal portion. You see the fused thalami over here, and the big ventricle that goes from one side to the other form. Okay, so the bowl form, because it has a coverage all over. This is another baby that has the pancake form. So here we dissect the skull, and here we have the brain. You see the frontal portion of the brain is present, but the most posterior portion is absent. This is a view from the back of the baby. You see the fused thymi over here, and you see the rim of cortex, which is anterior, but is not present on the posterior aspect, and this is therefore the pancake form. Now let's move to the semilobar holoprosencephaly, and that is where we start getting into trouble, because on the drawing it looks easy to recognize, but in real life, the differential diagnosis between lobar holoprosencephaly, agenesis of the septum pellucidum, hydrocephaly with disruption of septum pellucidum, is going to be a bit more difficult to make. Drawings are simple to make a description, but in real life it may be more difficult. So here we have the ventricles that are communicating. You can see that there's some separation between the ventricles. It's not a smooth curve like we had before. Now we have an attempt to differentiate the frontal horn, but not a complete version. And of course, this baby also have a very poor neurological outcome. Now we move to the lobar holoprosencephaly, and the lobar holoprosencephaly is also going to present some trouble because we have attempt of division here. We don't have an interhemispheric fissure, we don't have a fork, so we may have a hypoplastic fork, but it is not a complete fork, and so we have to recognize that. So one of the criteria that is recently published is the presence of the snake under the skull. This is the fused anterior cerebral arteries that are running in a groove under the skull in this location here. This is not an artery that we see normally. The anterior cerebral arteries are not typically visible in this shape here. So that is something you will want to do when you do cardiac Doppler in a sagittal section on these baby. Now here we have well-developed frontal horn. You see they're well separated. We have an interhemispheric fissure here, but the ventricles do communicate with one another at this level. Another example, you see a development of the frontal horn, and you can see that they communicate together, and there is no corpus callosum, and there's an anterior corpus callosum, but we have no cavum septum pellucidum. See a portion of the anterior corpus callosum, but the body is thinned out and is missing. So agenesis of the corpus callosum is not always complete. You may have dysgenesis. This is two different babies to show you the difference between fused and cleaved thymi. We'll talk about fused thymi in the A lobar, and here we have cleaved thymi, but still big monoventricle. Now, this could be easily confused if you read fast. This looks like you can see the cerebral peduncles, but this is not a normal anterior complex. We don't see the cavum septum pellucidum, we don't see the genu of the corpus callosum. So watch out for this kind of images when I review lawsuits about holoprosencephaly. It is usually this kind of form here where you see some frontal horns, but those frontal horns don't have the normal shape. They don't meet in the middle with the cavum septum pellucidum. So this is an image that is easy to mistake, and it causes some lawsuits. Now, lobar holoprosencephaly is non-lethal, but they have profound mental retardation and neurological problems, and hydrocephalus is commonly associated with the lobar holoprosencephaly. Now let's move to the synencephaly, or the middle hemispheric fissure, middle hemispheric variant. So here we have fusion of the hemisphere in the middle, so we don't have that separation, and we have kind of merging of the sylvian fissure from one side to the other. These will also have dysgenesis of the corpus callosum, and they may have partial separation of the thymi. So it's a rather complex form to recognize, and there are several articles that have been published recently in the literature. So here we see the frontal horn. They are diverging, but they are merging in the middle. You see they're fused over here. We don't have a cavum septum pellucidum. We have a cleaved thymus here. You see the frontal horn here. So no cavum septum pellucidum, merging of the two, and the particular shape in the frontal aspect with the communication in between. This is another example. You see the distended posterior horn, the wide anterior horn, but they are communicating. Again, we don't have a cavum septopellucidum, and in this baby there is no corpus callosum that is visible. Another example, large lateral ventricle. You see the fusion of the two ventricles, and more separate in the superior aspect, more fused in the inferior aspect, again, syntenoncephaly. Another example here from Moshe-Bernstein. You see the two thymi that are separate, and this, you see there is a partial intermittent fissure here and false. So this is a way to recognize it from the other form of holoprosencephaly. Holoprosencephaly, there is no prenatal diagnosis that I know of. What you look for is wide communication here. There's obstructive hydrocephalus and fused fornices that produce this echogenic dot in the middle of the coronal section. Now let's look at the facial anomaly in holoprosencephaly because that is an important aspect in the differential diagnosis of hydrocephalus. You don't only look at the brain, you always look at the face to see what kind of anomaly you can see. So this portion here of the precaudal plate is going to be the portion that induces the formation of the face, and of course you could expect the sonic hedgehog is going to be involved into that. And it set the median line for the face, it divides the forebrain into two separate hemispheres, and it divides the eye field into two fields also. So this failure of division here is going to cause a failure of division of the face. And it will go to some great difference between synophthalmic cyclopia, which is what you see over here, to hypotelorism and enlarged orbits. The nose can either be a proboscis with one or two nostrils, and we'll see the difference in just a second. Of course, absence of the nasal bone. And in the forehead, you may have absence of the metopic suture and a hypoplaxic maxilla that can go to complete absence. So let's look at the different form that we'll see. So if we compare to the normal fetus here, in hypotelorism, you see that the two eyes are closer. You may have also microcephaly in those baby. You may have a cleft palate, so you want to do a cross-section of the upper dental arch. And this is, I think, very difficult to see. You can have a single maxillary incisor. So if you look at the teeth bud, you can try to see that there's an asymmetrical number. But this is really difficult. The hypotelorism is the easiest thing to recognize. You remember that you can measure hypotelorism, but you can also just eyeball it. The distance between the orbit should be equal to the orbital diameter. So if you have the distance between the orbit equal or less than the orbit, you have hypotelorism. The next more severe here is cibocephaly. In cibocephaly, you have a proboscis-like nose, but it has only one nostril. So instead of two nostrils, look for one nostril, and that is something which is better done either with some tangential section with ultrasound or with 3D reconstruction. The next further up step is the median cleft. So now we have a cleft in the middle of the mouth, not on the lateral side like we have in the orofacial cleft. It's in the middle of the mouth and it extends into the nose. Very characteristic. The next further step is the ethmocephaly. Now we don't have the nose in the proper position. This is replaced by a proboscis, which is above the eyes, and the eyes typically are either fused together or they're extremely close together. In the case of cyclopia, the eyes are fused together, you have a single orbit, and then the worst situation is autocephaly, in which now we have a complete disruption of the first branchial arch, and you have an abnormal midline position of the ears that are fixed in the middle of the neck. The mouth is very hypoplastic and not visible, and the eyes are also abnormal. So let me show you some example of this different form of facial anomalies that you can see in holoprosencephaly. So here we have a case of hypotelorism. If you look at the distance between the eyes, again the distance is closer than the orbital diameter. another case of Nguyen. And I told you this is a lecture in which she has contributed a great number of cases. Here's an example in which I think it's interesting to look at the 3D compared to the 2D. If you look at the 3D, you may say, cute little baby, but actually when you look at the 2D, you see that clearly the interocular distance here is less than the orbital diameter. So this baby clearly has hypotelorism, and this is a baby which otherwise has holoprosencephaly, which is not seen on this particular image. Other example now, this is SIEU. We have a nose that has a single nostril. The single nostril is visible here, and it's visible here on the 3D. Also, this baby has hypotelorism, but again, I prefer a cross-section for the eyes instead of the 3D reconstruction to look for hypotelorism. So this was SIEU, and now we have the median cleft syndrome. So now we have a nose that is connected to the mouth by a wide gap. You see this wide gap, and that gap is exactly central. It's not going from one nostril to the mouth, it's going from both nostril or the single nostril to the mouth. And of course, this is associated very much with trisomy 18 and 13, median cleft syndrome. Another example, you can see this big gap in between. You see there's also some midface hypoplasia. The midface is displaced posteriorly. You can see the gap here in the lip, and there's also a gap in the palate at this level. So they also have midface hypoplasia and this retro position of the midface. Here's another case from Nguyen, and you see a baby has ethmocephaly. You see this one has two nostrils. You see the nostrils over here, and you see the fused eye under the nostril. So this is similar to the drawing here. This is a case of ethmocephaly. Next here is another ethmocephaly. You see the two orbits here are fused together, but you can see the two lenses are separate. You can see the proboscis over here, typical of ethmocephaly. Another example of ethmocephaly, you see the fusion of the two orbits. You see the two orbits are close together, that are partially fused. Another example here, another ultrasound image of that over here. These are rather easy to recognize prenatally. So when you do a diagnosis of suspicion of holoprosencephaly, always look at the face. Another example here, you can see the two eyes very close to each other over here. You see the holoprosencephaly. You see the two orbits here are next to each other, and the effect at this level. Another example here with proboscis and synophthalmia. You see the eyes are merged in the middle, and the proboscis is over the single orbit here. And then here we have a baby that has a sensible cephalocele and hypotelorism. You see there's something protruding in front of the face, in between the orbits, and the baby has hypotelorism. And of course, the head also had alobar holoprosencephaly, so multiple facial anomaly associated with that. And now the most extreme form is the autocephaly or the Ignatia holoprosencephaly. You see the orbits are difficult to recognize. There's a tiny dot here for the mouth, and the ears are fused in the midline over here. This is another example here where the eyes are a bit more visible. The nose is in the midline here, and the ears are fused in the midline. So this is the typical finding that you see in autocephaly or the Ignatia holoprosencephaly version. So this is what I wanted to show you about holoprosencephaly, and now I'm going to finish by going to the septoptic dysplasia. And septoptic dysplasia is very hard to recognize from holoprosencephaly. So if you look at the conditions that have absence of the septum pellucidum, there will be two types of disorder. One, which is the septoptic dysplasia, that has no septum pellucidum and hypoplastic optic nerve and chiasma and pituitary hypoplasia. And then the other condition, which is an isolated absence of the septum pellucidum, but be careful that 25% of baby in which we believe there is absent of the septum pellucidum, which is isolated, 25% of this baby postnatally have septoptic dysplasia. So this is really a diagnosis that you have to handle with a great amount of care, because we have a tendency to miss findings when we do the examination. So let's start with the septoptic dysplasia, and you see the big difference diagnosis here is going to be with holoprosencephaly, and it's difficult to recognize one from the other. So absence of the septum pellucidum is important. Hypoplasia of the optic nerve, optic chiasma, and I don't know how many of you can do that, but you can do some 3D reconstruction of the optic chiasma in the second portion of the second trimester, and this is a very difficult thing to do. Very few people in the world can do that. I have tried to do some myself, but I don't have the technical skill most of the time. There's some mutation or different genes that can do that. This is a rare anomaly. It has a low recurrence rate, but it may be associated with other anomalies. Schizencephaly, quite typical. 70% may have bilateral schizencephaly, and of course the prognosis there will be related to the schizencephaly more than the septoptic dysplasia. You can have perisylvian polymicrogyra, which is something that is usually seen after birth, not prenatally, but you can see a smooth cortex on some of these babies. The holoprosencephaly, the septoptic dysplasia, and lobar holoprosencephaly overlap very much. Sometimes you need postnatal MRI to recognize. They will have ventriculomegaly, dysgenesis of the corpus callosum. They may have craniofacial anomaly, and then they will have multiple endocrine functions. So not only the anatomy, but the physiology of this baby is going to be abnormal, which prenatally does not affect them, but of course it's going to be important in the management of those babies if the patient continues the pregnancy. So the finding here, this is a normal exam compared to the baby that have a septoptic dysplasia. You see the absence of the cavum septum pellucidum. Remember, absence of something is always harder than demonstrating the presence. There will be fusion of the frontal horn at this level. The corpus callosum may be present, but it may be thinner, so you have to look at a cellular section over here. The force is seen normally, so that's a differential diagnosis with the holoprosencephaly, and this baby will present with ventriculomegaly. So these are the key findings that you have to search when you're looking at this baby. Now here's an example of lobar holoprosencephaly. You see there is some division of the cortex at this level, but you don't have the forks. You see here in septoptic dysplasia, the forks is present aside from the division. So this is a different type of entity, and this is one of the criteria. But however, you see they both have absence of the cavum septum pellucidum, and they both have merging and fusion of the frontal horn. So if you see a baby that has a corpus callosum, go more with a diagnosis of septoptic dysplasia than with lobar holoprosencephaly. Now, they are both similar because they are missing the cavum septum pellucidum, but in septoptic dysplasia, you don't have the optic chiasma. And this is an example of a dissection of the optic chiasma by one of my friends in Moscow, and she is very skilled at recognizing the optic chiasma. And not only you can find it, but then you can measure it. And here the measurement is very simple. The optic nerve size should be the gestational age divided by 10. So if you have a 20-week fetus, it should be 2 millimeter. If you have a 36-week fetus, it should be 3.6 millimeter. Now, for those of you who are experts at doing some 3D dissection, if you have good optic chiasma, please send them to me, because I would include them, because not so many people can do that. So, when it's associated with holoprosencephaly or schizencephaly, the prognosis is going to be poor and reflect the prognosis of the associated anomalies, so holoprosencephaly or schizencephaly. When it is isolated and not simply absence of the cavum septum pellucidum, so you have optic chiasma atresia, but you don't have just a simple cavum septum pellucidum absence, then the outcome will have visual impairment, hypopituitarism, cerebral palsy, and developmental delay. So even if the condition is as favorable as possible, the prognosis for this baby is very poor. This is a baby we had a couple of years ago. You see there is a wide interhemispheric fissure. The corpus callosum was absent in this baby. There was merging of the ventricle. She also has an intraventricular bleed. And she survived a few years. You see the facial appearance is quite normal compared to holoprosencephaly, but she had intractable epilepsy and associated hormonal deficiency, so she could not survive. Here's another example where you have some borderline size of the lateral ventricle. They measured 12 millimeters. There's no cavum septum pellucidum. You see the absence of the cavum septum pellucidum and the merging of the frontal horns. Here you can see portion of the interhemispheric fissure. You see that the corpus callosum is present on the front, but look at the thickness of the corpus callosum here and the thickness of the corpus callosum there. So this baby has an irregular corpus callosum. So pay attention not only to the presence of the corpus callosum, but to the morphology of the corpus callosum. So here again, absent cavum septum pellucidum, you have merging of the two ventricle in front of each other. You have an intact forks, and you have fused anterior horns. And now let's move to the isolated absence of the septum pellucidum, and this is something which you have to treat very carefully because 25% of the cases that have been reported in literature as being absent of cavum septum pellucidum ultimately end up having septum optic dysplasia. So we underrepresent the septum optic dysplasia in this group. Now these babies, even if they have everything normal, may have anomaly of the limbic structure. They may have heterotopia, so you want to look alongside the ventricle to see if you have an irregular size of the ventricle. If you have nodules, they may have a hypoplastic forks, and they may have ventricular cleft. So they're not out of the woods because you can see the absence that is isolated. So here's an example where there is absence of the cavum pellucidum. The frontal horn are merging in the midline here. You see the corpus callosum over here, and that baby was followed for several years, and by the time the baby was 14 months, all MRI had been normal, or the physical development and the neurological development of the child was normal, and there was no endocrine function. So this confirmed the fact that this was an isolated absence and not a septum optic dysplasia. This is another example. Here you can see the merging of the ventricles over here. You can see the corpus callosum and no septum pellucidum in between. So this is a well-established case. So this is what I wanted to talk to you about in the ventral induction. So thank you very much for your attention.